Welcome all. I am Dr. Kailash Suresh Kumar, Professor of Psychiatry from Chettinad Hospital and Research Institute. Today we will be discussing on the topic parasomnias with few case studies. We will discuss about the definition, classification, pathophysiology of parasomnias, understanding the clinical features of individual entities, how will you approach a patient of parasomnia, how to identify the red flag signs for investigations, and the evidence-based management. So what are parasomnias? The etymology of the word parasomnias, the word para literally means beside, somnus means sleep. So parasomnias are undesirable physical events and experiences that occur during entry into sleep, within sleep, or during arousal. The clinical significance is that is a disorder primarily in parasomnias overall, primarily is a disorder in children, and the impact varies from it being benign, gradually improving with age, or sometimes there can be injury during the episodes, or there can be underlying neurological or psychiatric disorders which we'll have to evaluate and treat. So for understanding the clinical features of parasomnias, we will need to know a bit about the sleep cycle. A person, when he is awake, gradually moves into the N1, N2 lighter sleep, then goes into the N3 or the deep sleep, slow wave sleep. This is the dark blue represented by the deep sleep N3 stage, then moves up again back to N2, N1, goes to the REM sleep. This dark red one is representing the REM sleep. So as we observe, as the night passes and the early morning happens, the REM sleep, NREM sleep is more predominant in the first 1/3, whereas the REM sleep is more in the last 1/3. NREM parasomnias occur in the N3 or the deep sleep stage, and REM parasomnias occur in the last 1/3 of the sleep. The other thing we note here is, compared to young adults, the older adult, the dark blue area, that is the deep sleep, keeps on decreasing. So what we can understand is NREM parasomnias occur in the first 1/3 of the sleep, and it's more common in children, whereas REM parasomnias occur in the last 1/3 or the second half of the sleep and can occur in any age, but REM sleep behavior disorder is more common in people greater than 50 years. So what is the pathophysiology? It is explained by the concept sleep state dissociation. That is, normally there is complete transition between the sleep stages which I normally mentioned, like wakefulness, N1, N2, N3, then REM. There is complete transition, but in parasomnias there is incomplete state transitions which results in hybrid states with mixed features. For example, in NREM parasomnia, some bit of wakefulness, that is incomplete arousal, comes into the N3 sleep. There is N3 sleep, that is the deep sleep. Like there is also motor autonomic activation. We would also be able to understand that the NREM parasomnias, predominantly a disorder in children, gradually improves with age as the brain maturation improves. In REM parasomnia, normally there is atonia or paralysis of the motor neurons or motor muscles of the body. So this is a function of the GABAergic neurons which causes inhibition. When there is dysfunction in this GABAergic neurons, this paralysis or REM atonia doesn't occur and leads to parasomnias. The most important factor of REM parasomnias is that it can be a prodromal feature of neurodegenerative disorder. So we will be able to see that both in NREM parasomnia occurs when there is the brain maturation is gradually only happening, and in REM parasomnias it can be a prodromal feature of neurodegenerative disorder which also indicates some amount of brain dysfunction. So we'll understand the concept with starting with the case scenario. 7-year-old boy brought about by the parents, where he abruptly sits in the bed and starts screaming. So how will you approach the case? How will you diagnose? What are the further details you need for diagnosis? And whether you will investigate the child or not? What will you tell the patient and the parents, whether it's a benign condition or a dangerous condition, or how will you treat the child, whether using medications or non-pharmacological methods? To answer these questions, we need to know some details about the individual entities. So, before going into the individual entities, the classification, the international classification of sleep disorders, that is ICSD-3, classifies the parasomnias. The two main categories, the NREM parasomnias, has 5 subcategories: the disorders of arousal, that is confusional arousal, sleepwalking, sleep terror, sleep-related eating disorders, and sexsomnias. Whereas the next important category, REM parasomnias, has 3 main categories: REM sleep behavior disorder, recurrent isolated sleep paralysis, and nightmare disorder. There are few other important things in other parasomnias about which we will also see briefly. Before moving on to the individual entities, apart from learning the differences between NREM and REM parasomnias, this slide will also help you to understand the general principles of NREM and REM parasomnias. Like we already discussed, NREM parasomnias occurs in the first 1/3 of the sleep, and it is more common in children, and there is also strong family history. On the other hand, REM parasomnias occur in the last third or the second half of the sleep, and there is less family history. In this, the other features are the motor movements which occur during the NREM parasomnias are purposeless, and there is no memory of these episodes when the person wakes up the next day morning. Whereas here in REM sleep, it is usually the dreams are more vivid, and there can be dream enactment behaviors where they act out on the dreams, and the patient remembers these episodes or the dreams and tells about it the next day morning. The one other thing is, when you try to awaken the patient, it's difficult in patients of NREM parasomnias, and there will be high autonomic activation, whereas it will be easy to awaken the patient in REM parasomnias. When comparing the triggers, sleep deprivation, sleep fragmentation caused by stress or fever or medication can trigger NREM parasomnias, whereas the underlying neurodegenerative disorder is the main reason for REM parasomnias, and some medications can also cause it. So, the main treatment is non-pharmacological for NREM parasomnias with sleep hygiene, safety measures. Only in severe cases, low-dose clonazepam is suggested. But for REM parasomnias, the most important thing is we should identify the underlying cause, underlying neurological disorder, and treat it. For the episode, melatonin or clonazepam is known to help. Moving on to the individual entities, the first NREM parasomnia which we are going to see is called confusional arousal, as already mentioned, more common in children with family history, and in this there is incomplete arousal from N3 sleep stage, that there is dysfunction of the ascending arousal systems. Clinical presentation is, typically it will be easy for you if you just visualize how the patient will present. The parents bring the child, saying that the child suddenly wakes up and sits up in the bed, and he appears confused. They try to wake him up. He is not awakened easily and gradually goes to sleep in some 5 to 15 minutes. Now in the morning he doesn't remember about these episodes. So in these sort of recurrent episodes of incomplete awakening alone from sleep, which happens in the first 1/3, we call it as confusional arousal. How do you differentiate it from sleep terrors? Sleep terrors has fear and autonomic activation also during the episodes. In sleepwalking, there is ambulation, that is, the people also walk during these episodes. In nocturnal seizures, there is brief, stereotypical, repetitive movements, along with other features of seizures can also be there, like urinary incontinence and tongue bite. So after making the diagnosis, how do you treat? Is primarily you reassure and educate the parents that it is benign and gradually improves with age and brain maturation. Sleep hygiene is one thing which will help reduce the frequency and the severity of the episodes. Consistent sleep-wake schedule, adequate sleep duration around 10 to 11 hours for children. How do you differentiate this from sleep terrors? In sleep terrors, there will be fear and autonomic activation. In sleepwalking, the person during the episodes will get up and start walking. There will be ambulation. In nocturnal seizures, there will be brief repetitive movements with features of urinary incontinence, and tongue bite can also be there. So once we make a diagnosis of confusional arousal, The first line of management is non-pharmacological, where we reassure and educate the parents, conveying to them that it gradually resolves as age increases and with brain maturation. Sleep hygiene measures like consistent sleep-wake schedule, adequate sleep duration for around 10 to 11 hours for children, and comfortable sleep environment without distraction. Avoiding caffeine, heavy food, and stimulating activities before sleep can all help to reduce the frequency and the severity of the episodes. If it is further severe, low dose clonazepam can also be given. Moving on to the next NREM parasomnia, which we commonly call as somnambulism or sleepwalking. It is typically occurring in 4 to 8 years of age, peaks at 8 to 12, and there is a strong genetic component and few HLA locus has already also been identified. It typically occurs around 90 to 120 minutes after sleep onset in the first 2 to 3 hours, where the child usually gets up and sits from the bed and starts walking around in the room with a blank staring face, and when parents try to wake up, it's difficult to awaken and the child is unresponsive to them, and gradually the child goes back to sleep and there is amnesia for the episode the next day morning. If it is only till this level, then it is fine, but sometimes there are some dangerous behaviors, like the child tries to leave the house, climbing out of windows, operating machineries can be seen, and driving vehicles also, though these things are rare, but they have been reported. Most important thing is that these episodes can be precipitated by sleep deprivation or fragmentation because of multiple reasons like irregular schedules or medical illnesses like fever. In adults, sleep disordered breathing like obstructive sleep apnea, periodic limb movement disorder, gastroesophageal reflux disease, medication use like sedative hypnotics, especially the Z group of drugs like zolpidem, and CNS depressant can cause a paradoxical agitation and precipitate the sleep waking episode. So a proper history about these things have to be obtained. Coming to the management in children, the general principles of NREM parasomnias like reassuring, sleep hygiene should be followed. Here the safety measures start becoming important. We can suggest floor mattress to them and secure the dangerous objects from the bedroom, kitchen. Installing doors, gates and window alarms. Motion activated lights can be used to alert the bed partner or the family members. When there is a predictable NREM parasomnia, that is, when it occurs at one particular time of the night, we can plan something called as scheduled awakening, that is gently awakening the child around 15 to 30 minutes before the typical episode. This can be continued for around 2 to 4 weeks and we can gradually taper. If severe, similarly we can give clonazepam low dose or gabapentin, topiramate, imipramine have also been tried. The next NREM parasomnia, the third one, is sleep terror or night terror or fever nocturnus. It's peaking at around 2 to 4 years of age and resolves by adolescence. The family history percentage is further high, around 80 to 96%. Apart from the incomplete arousal from the N3 stage, there is also preserved fear response, that there is amygdala hyperactivation in these disorders. It's the most dramatic form of NREM parasomnia, where the child suddenly wakes up from the sleep with a scream. There can be screaming, thrashing, flailing, attempting to flee, difficult to awaken. The child will also have profuse sweating, rapid breathing, pupillary dilation, which all indicate extreme autonomic activation. The duration will be around 1 to 10 minutes and gradually the child will go to sleep and there will be complete amnesia for the episode. So these sudden arousals from slow wave sleep with intense fear and panic is called sleep terror or night terror. We have to differentiate from nightmares, which is a REM sleep phenomena, other nocturnal panic attacks or sleep related movement disorders. During these things, the person will be aware of what's happening. We have already discussed how to differentiate these episodes from nocturnal seizures. So, after making a diagnosis of sleep terrors, the management will be in children. The general principles of NREM management is followed, but regarding how to manage during the episodes, it's better not to wake up the child because sometimes it will lead to the child becoming agitated, violence. It's better to speak to the child in a calm voice and ensure their safety and remove any hazards which are nearby. Next coming, the fourth thing is sleep related eating disorder. More there is a bit more female preponderance typically in late adolescence or early adulthood. There is also around 8 to 15% of daytime eating disorder comorbidity in this. Along with dysfunction of sleep wake transitions, there is also altered hypothalamic feeding circuits in this. Patients present with recurrent episodes of involuntary eating during the sleep period. It will be more involuntary, and the patient will be eating in a messy manner, poor cooked food. Sometimes this foods can be harmful also, very rapid way, high calorie food they will be eating. This we will have to differentiate from normally waking up in the night and eating. So there will be features of NREM sleep disorders like dysfunctional behaviors during arousal, impaired consciousness during eating, and amnesia the next day. Sometimes it can become dangerous when the person is preparing food in this impaired consciousness. Long term it can cause weight gain and adverse health consequences and sleep disruption. So we have to differentiate from other eating disorders like bulimia nervosa, binge eating disorder and nocturnal eating disorder. Also from Klein-Levin syndrome, there will be hypersexuality, hyperphagia and hypersomnia predominantly. These features, associated features, can help us differentiate. Sleep related eating disorder is related to restless leg syndrome, and it mimics the non-motor symptoms of restless leg syndrome. So when moving on to the management, apart from the usual NREM general management principles, removing the dangerous kitchen appliances, locking the refrigerator, having alarms and motion sensitive lights can also help us. Apart from clonazepam in the pharmacological management, topiramate can also help in these patients as it has appetite suppressing properties. Moving on to the last NREM parasomnia, which is sexsomnia or sleep sex. It's a rare disorder coming from N3 slow wave sleep. It's more when it occurs in adults. There are triggers like obstructive sleep apnea, Parkinson's disease with impulse control disorder, shift work, or medications like SSRIs or zolpidem's recent use. This clinical features, there can be wide range of hetero and auto-directed sexual acts like violent masturbation, complete sexual intercourse, spontaneous orgasms, loud sexual vocalization, but all with partial or complete loss of conscious awareness and amnesia for the same the next day. It's a rare disorder. There's limited evidence. Clonazepam can be used in severe cases, but the mainstay of treatment is there can be treating the underlying problems like obstructive sleep apnea by using CPAP. There can be some forensic implications also for this disorder. So moving on to the REM parasomnias. This is a very important disorder, that is RBD, REM sleep behavior disorder. Like we saw, in contrast to what we saw in NREM parasomnias, this parasomnia occurs in older individuals greater than 50 years, and there is a strong male preponderance. There is a prodromal, this disorder can be a prodromal marker for neurodegenerative alpha-synucleinopathies disorders like Parkinson's disease or dementias. This represents a dysfunction in the GABAergic inhibition of motor neurons. So there is a loss of normal REM atonia. That is, normally in REM sleep there is atonia. Because GABAergic inhibition doesn't work well, this REM atonia is lost, leading to these parasomnias. The typical clinical presentation is in the last third of the night, that second half of the night, where there is repeated episodes of sleep related vocalization or complex motor behaviors. In sleep there is vocalization, motor behaviors. There is something called as dream enactment. They feel, they act out on dreams in which they feel that they are being chased, they are fighting or screaming. It's easy to awaken the patient and they have a vivid recall of what is happening. How to differentiate? We'll have to differentiate it from NREM parasomnias, nocturnal seizures, just the limb movement disorders where the impairment of awareness during those episodes will not be there. There's another disorder called sleep related groaning, which is called catatonia. We'll also have to differentiate it from that. The most important thing about REM sleep behavior disorder is for establishing a diagnosis. Video polysomnography is mandatory and we have to establish REM sleep without atonia in that. Okay. So apart from the usual non-pharmacological management, the most important thing is identifying the underlying neurological disorder. Neurological evaluation has to be done. If needed, the imaging or other treatment of that should be done. Pharmacologically, apart from clonazepam, which is usually used, it works by GABAergic muscle relaxation. Melatonin is also being used a lot nowadays. It promotes the REM atonia restoration, but more than that, it has whatever the side effects clonazepam has, that melatonin doesn't have, like cognitive dysfunction or increased risk of falls. There is a dependence tendency in clonazepam. All these things are not there in melatonin. So melatonin has been started to be used as a first line. Pramipexole, donepezil, rivastigmine have also been used. The main crux of REM sleep behavior disorder is having a neurosurveillance and following it up for whether any onset of neurodegenerative disorders. The next REM parasomnia is nightmare disorder. The onset is typically in childhood, peaks at around 3 to 6 years. Many of us would have also had a nightmare. It peaks in late childhood and early adolescence. So it's a REM disorder which is more common in children. Okay, and there can, especially in children who have trait anxiety. But when the onset occurs, there is new onset in adults, we will have to think of psychological trauma or any new medications use. What happens in anxiety is there is hypervigilance in the daytime. This gradually extends into the REM sleep also. There is hyperactivation of amygdala, altered noradrenergic system and intrusive memory processing. This nightmare can be primary or secondary to psychiatric disorders like PTSD and other disorders and medical disorders and use of any medication. So we will have to take an history to identify the underlying cause. So in general, there is repeated occurrences of extended extremely unpleasant dreams alone. The person has extended unpleasant dreams in the second half of the sleep, that is in the last 1/3. Dreams are well remembered upon awakening. The dream quality is almost close to real, vivid quality. There is a logical story lines to it and the patient clearly remembers it. The content will be threat to survival, security or physical integrity of the person. So that produces a fear response also in them. The differential diagnosis is sleep or night terrors, which occurs in the first 1/3. REM sleep behavior disorder, which is more common in old individuals with dream enactment and nocturnal panic attacks. We request the parents to give us a 2-week sleep diary about what is happening, what is the sleeping pattern and the episode frequency and duration. The first line is psychological intervention treating the underlying psychological trauma or psychiatric disorders. If for nightmares specifically, there is cognitive behavior therapy for nightmares, which includes sleep hygiene education, cognitive restructuring, that is if there is some faulty cognitions or thought processes, an attempt to restructure it is done, relaxation training, all these are planned. There is another technique called as imagery rehearsal therapy or IRT, where we write down the nightmare, change the ending to positive, rehearse when awake. These whatever they have written, we rehearse when they are awake and practice it, so that gradually the nightmare frequency starts reducing. When this PTSD, nightmares are associated with PTSD, prazosin, an alpha-1 antagonist, is used to reduce these nightmares. Cyproheptadine is used in children, trazodone, gabapentin, clonazepam have also been tried. The next one is recurrent isolated sleep paralysis. It peak prevalence around 15 to 25 years. What normally happens is in REM sleep there is atonia. This REM atonia persists into wakefulness, that is consciousness returns before motor control. There is amygdala hyperactivation also during this time, fear response also happens. Psychological stress or sleep deprivation is a common trigger. There is a temporary inability to move or speak during transition between sleep and wakefulness. That is, the patient is aware of the environment and surroundings. He is conscious but he is not able to move his body. Maybe can be accompanied by hallucinations and fear. It has to be differentiated from narcolepsy, RBD and periodic paralysis and seizures. We have to first treat the underlying condition like stress or sleep deprivation. Non-pharmacological means first line. If it is severe, here we prefer SSRIs like fluoxetine or TCAs, SSRIs like fluoxetine and TCAs like imipramine, because they are known to suppress the REM sleep and thereby reduce the REM atonia persisting into wakefulness. Treating the comorbidities and avoiding triggers is also important. Few words about other parasomnias: exploding head syndrome, sudden loud noise or explosive sound sensation during the sleep-wake transition. There is no physical pain despite the auditory experience. Few seconds to minutes with full retention can happen. Reassurance and sleep hygiene is usually enough. Sleep talking or somnology, it is characterized by vocalizations with varying degree of comprehensibility. It is considered as an isolated symptom or normal variant in the category of parasomnia. The next important category is parasomnia due to medication or substance. There is a temporal correlation between the occurrence of this parasomnia and using the substance or the medication. The common agents are alcohol, sedative hypnotics, antidepressants, antipsychotics. The Z group of drug, that is zolpidem, is known to precipitate sleep related eating disorders and sleepwalking frequently. This is a very important part of the discussion, that is, when a patient is coming with the parasomnias, what are the red flags which are seen when we prefer to do video polysomnography or electroencephalogram. Normally, in all patients of NREM parasomnia, which we already discussed, we don't do these investigations. Only when if it is atypical, that is when there is an adult onset greater than 40 years, when there are stereotypical, brief, repetitive movements which are of high frequency and occurring at any part of the night. This indicates to us that it could be a nocturnal seizure or any other phenomena. Then we have to do these investigations. If there is associative dissociative symptoms and psychiatric comorbidities also, these investigations are done. The other indications are, as we already mentioned, if there is suspected RBD, REM sleep behavior disorder, video polysomnography is mandatory. Differentiation from sleep related epilepsy, we have to do the video polysomnography with extended EEG montage. The other indications are medico-legal implications to have objective evidence, failure of conservative treatment, high risk of injury, ambiguous clinical presentation, and identification of comorbid sleep disorder, especially the sleep related breathing disorders like obstructive sleep apnea or movement disorders. We will have to identify this because they are known to fragment or cause sleep deprivation and trigger the parasomnias, so we can plan targeted treatment accordingly. So knowing these red flags is very important, then only we can plan for the investigations as mentioned. So how can we approach a patient with suspected parasomnia? So when a patient presents with abnormal sleep behavior, we will have to obtain the history from patient and bed partner. We have to obtain details of the nature of the episode, frequency, timing, duration, recall, if there are any injuries, are there any vocalizations in these episodes, what are the triggers and precipitating factors so that we can avoid it, assess whether there is any safety risk, and do a physical examination. We can request the parents to give us a 2-week sleep diary. And the next important step is to know whether there are red flags present like adult onset, injury risk, stereotypical brief movements which occur at any part of the night. So if it is there, if these red flags are there, we will plan for video polysomnography with full EEG montage, and if it indicates the parasomnia, we will treat according to the parasomnia identified. If it indicates other disorders like epilepsy or obstructive sleep apnea, treatment for those disorders have to be done. If it is normal study, then we will consider repeating the polysomnogram because we will have to catch that particular episode of the parasomnia. So repeating it can give us an increased probability of finding it. If there are no red flags and there are only typical features, first line of management is conservative treatment, that is sleep hygiene and safety measures. If there is adequate response to that itself, we will maintain long-term follow-up of the patient and monitor the response. If there is poor response to the non-pharmacological methods, we can escalate treatment with pharmacology, medicines and a specialist referral, and gradually increase it and add behavioral therapy, psychological interventions also. So we started with this boy's case scenario on exploring. These are the details we had got further. Usually these episodes happen around 2 to 3 episodes per month, lasting 3 to 4 minutes, usually typically around 11:30 to 12 in the midnight. But in the last week there has been 2 such episodes when the child's sleep was disturbed when there was fever with respiratory infection. So during these episodes he abruptly sits up and starts screaming in fear with his eyes wide open, and there is rapid heartbeat, sweating. Parents try to console him but he is not aware of them being nearby. After a few minutes he calms down and doesn't remember it the next day morning. In one such episode he injured his forearm and forehead, and there are no red flag signs or atypicality. There is also similar history in the mother. So what do you think would be the diagnosis of the 7-year-old boy? Yeah, it's an NREM parasomnia, which is sleep terror or night terror. So this management which we had already discussed, the education, reassurance, immediate management, not waking up, sleep hygiene, safety measures. Because it's a predictable parasomnia usually occurring at around 11:30, we can plan the scheduled awakening around 15 minutes before. With all this non-pharmacological management, if it doesn't settle down in a period of 4 to 6 weeks, we try to give them low dose clonazepam for a period of 4 to 6 weeks, and when he is better we can gradually taper and stop the clonazepam. So now in contrast to this previous case, we saw a 70-year-old man, a retired school principal, brought by his wife with concerns about nocturnal behaviors for the past 3 years. The episodes happen 4 to 5 times per week, typically in the early morning hours, the second half of the sleep. He shouts, curses, thrashes, sometimes punches, kicks, and falls out of the bed. When awakened, he vividly recalls the aggressive dream content matching his behaviors, like as though he was fighting or defending himself from people who were trying to harm him. These behaviors have resulted in minor bruises for the wife also, and also he has fallen down and broken nose for the patient. On examination, neurologists found a subtle tremor, reduced arm swing on recent examinations. So what do you think is the diagnosis? Yeah, as we mentioned, it could be REM sleep behavior disorder, but before establishing a diagnosis, we need video polysomnography to establish REM sleep without atonia. And the management we have already discussed. The most important aspect would be that this patient also had few Parkinson's symptoms, so evaluation for that, imaging if needed, and treatment and follow-up, long-term follow-up would be the important thing which this REM sleep behavior disorder would indicate to us. So the take home message is parasomnias are diverse. It can be NREM, REM, and the basic concept to understand that is sleep state dissociation. In a clinical evaluation of patient, safety assessment and identifying the red flags becomes important. If identified, we'll have to do a video polysomnography and electroencephalogram to establish a diagnosis. The first line of management would be non-pharmacological intervention, and if there is poor response or if the symptoms are very severe, then medications can be tried and gradually tapered and stopped. Recognition of the strong association between REM sleep behavior disorder and neurodegenerative diseases like Parkinson's, dementia underscores the importance of accurate diagnosis and appropriate long-term monitoring. So these are few references for further reading, and thank you for patient listening.